So, good evening to one and all. So, today we are going to have a very short lecture on an approach to broad complex tachycardias. We already did a lecture on the approach to narrow complex tachycardias in January, I think. We have also done other lectures on ECG reading, the basics of ECG reading. We have 2 videos of that. And those are available on the group in case you were unfortunate to have missed that the first time. So today we are just going to focus on broad complex tachycardias and how we should approach them in the emergency department. So we'll just review how to approach rhythm analysis on an ECG. So the basic 3 questions are always the same. First of all, are there P waves or not? So the best leads for looking at P waves are going to be either lead 2 or V1. So lead 2 or V1, these are the 2 best leads to look for P waves. Second question is each QRS complex preceded by a normal P wave or not. And the third question is whether the RR interval is regular or irregular. So these are the three key questions to asked to decide whether the rhythm is normal or abnormal. So whether it is a sinus rhythm or whether it is something else. So if you're talking about tachyarrhythmias, there are 6 basic types of tachyarrhythmias. For the most common is obviously sinus tachycardia. When you get a fever, your heart rate goes up. That is sinus tachycardia. Multifocal atrial tachycardia, common in COPD patients, have 3 different morphologies of the P waves, and the rhythm will be irregular, similar to atrial fibrillation. Then you have atrial flutter, which can be both regular or irregular. Atrial fibrillation, which is irregularly irregular, and there won't be any definitive P waves visible. Then you have something called supraventricular tachycardia, so which is actually a broad term which can be used to refer any one of these. So it can be NRT, AVRT, or atrial tachycardia. And the reason why we say this is because if you look at the ECG, it might be difficult to actually differentiate these 3. And the management in general does not really differ that much. So we generally like to lump them up into the SVT category. Although there is some difference in terminology, some people just assume that SVT is equal to the AVNRT, so which is actually not exactly the right use of terminology, but so it doesn't really matter that much when you're practicing. And finally, ventricular tachycardia. So of these, so which one of these is broad? Ventricular tachycardia. So ventricular tachycardia is always going to be broad. There can be some exceptions like idiopathic VTs, where the QRS complex is actually relatively narrow for a VT, but we're not going to go into that today for simplicity's sake, because that by itself requires another lecture. So, but VT is only one of these that is naturally broad complex. All of the other ones are supposed to be narrow complex, but if they are in conjunction with a bundle branch block, they can be broad. They can also become broad if they are in conjunction with something else that prolongs the QRS, like hyperkalemia, like WPW syndrome, pre-excitation. So those things can actually convert any of the narrow complex tachycardias into a broad complex. So the difficulty in diagnosis is going to be trying to differentiate what is actually VT and what is an SVT with a bundle branch block. So the basic principle, as always, is not going to be the ECG, it is going to be the patient. So the patient, we have to assess whether the patient is stable or unstable. So any tachyarrhythmia unstable, the answer is always going to be electrical cardioversion. There is absolutely no doubt about that. And how do you decide whether the patient is unstable? Basic ACLS. You look at the 5 things for instability, that is hypotension, signs of shock like cold peripheries, etc. Ischemic type of chest pain, not every chest pain, but if you think that it's actually an ischemic type of chest pain, that is automatically unstable. That is something that people actually forget. But ischemic type of chest pain equals unstable, and that patient you actually have to cardio electrically. Then any patient with altered mental status, unstable. Any patient with acute heart failure, that is also unstable. So you have to assess these things. So if you have these things, then the safest approach is always going to be electricity. But there are a couple of scenarios where electricity is actually not going to work. And as I said, these are the features of unstable, that is hypotension, signs of stroke, altered sensorium, ischemic chest pain, and acute heart failure. Electricity doesn't help with two things. One is sinus tachycardia, second is multifocal atrial tachycardia. In both of these things, the management is going to be to try to fix the underlying etiology. So in sinus tachycardia, whatever is causing the sinus tachycardia, like it's sepsis, like it's a GI bleed, obviously your antiarrhythmics are not going to help in any way with those kind of conditions. And with your multifocal atrial tachycardia, it is generally due to underlying COPD, and you have to, address that. So you trying to go for rate control or rhythm control in these two conditions are not going to really be productive, and electricity is not going to work. But in case you actually mistook something for these things for something else, and you gave an electrical cardioversion to a patient, you are unlikely to actually cause much harm to the patient. So if you are in doubt and the patient is unstable, do not be hesitant to actually use electricity those patients. So if you get a broad complex tachycardia, what is your thought process going to be? It has to be number one, number two, number three, VT. Number one, number two, number three is always going to be VT. Only afterwards do we even consider the diagnosis of SVT. Why? Well, generally, if you get a VT, you will generally take things more seriously, and generally we have a lower threshold to actually give electricity for those patients. With SVT, you are much more likely to play around, maybe give some antiarrhythmic, see what happens. And sometimes, if you do that, things can go very, very wrong. So if you give a patient with VT, diltiazem, then things can go horribly wrong. So that is why, in general, it is a safer option to assume that something is VT than to assume that something is SVT. Moreover, in adult patients, VT is going to be the more common diagnosis, especially in patients who are elderly. So they say age more than 35 years. Younger than 35 years, then you are, and the patient is very, very stable, then you just start thinking of other things. But once your age starts increasing, then the likelihood of VT also starts increasing. Similarly, a patient with any kind of heart disease, any kind of structural heart disease, ischemic heart disease, history of myocardial infarction, all of those things will automatically increase the risk of this being a VT, this broad complex tachycardia being a VT. And any kind of family history of sudden cardiac death, especially some hypertrophic cardiomyopathy, long QT syndrome, Brugada, etc., ARVD, all of these things also increase the risk of VT. So basically, any kind of abnormality in the heart, you have to, or an elderly patient, you have to think of VT. That is why in an adult patient coming with broad complex tachycardia, the most common diagnosis is generally going to be VT. It's slightly different in pediatrics. In pediatrics, SVT is actually more common than VT. So everything kind of changes around when it comes to pediatrics. So when do you actually think about an SVT? So there are multiple criteria that I'm going to get into later on. But for simplicity's sake, the only way you are going to consider VT is if the ECG is showing a perfect LBBB, RBBB morphology. What do you mean by perfect LBBB, RBBB morphology? You look at three leads, as I always say. You look at three leads: lead 1, V1, V6. Lead 1, V1, V6. In V1, in RBBB, you get a RSR dash pattern. In lead 1 and V6, you get a slurred S wave pattern. So we'll see what that means. So if you get that pattern, it's an RBBB morphology. In LBBB morphology, you get in V1, you get a QS morphology that is basically negative Woodley wave. And in lead 1 and V6, you get a positive Woodley wave, that is monomorphic R wave. That is LBBB morphology. And it has to be perfectly matching in all of these three leads. If it is not really matching with all of these three leads, you throw out the diagnosis of SVT with bundle branch block. Secondly, you need to have a baseline ECG that is showing the exact same morphology, the RBBB or the LBBB. If you get a baseline ECG that is showing the exact same morphology, that favors the diagnosis of SVT with bundle branch block. This is the safest approach to this thing because everything else that I'm going to teach you today is going to be complicated. And when it's complicated, there is a higher risk of error. And in the emergency department, we don't have a lot of time to make these kind of decisions. And I would recommend you. So whenever you are in doubt, you just follow the 2-3 sites that I've just mentioned right now. Now, for your exams, you will actually have to understand the criteria that are used to differentiate SVT and VT. But you have to understand that despite what your faculty might have told you, none of these criteria are perfect. None of them have 100% sensitivity and specificity. That is why I'm not a fan of using the criteria, because if a patient is having VT and the last thing you want to do is to go through a lengthy algorithm to actually read the ECG and figure out that it was actually VT, because then you're just wasting time. Patient can become more unstable, and I've seen people doing this. People would get a broad complex tachycardia, then they'll decide that okay, now is the time to actually we'll go through the whole algorithm, and don't do that. So because patients are unstable, you do the simple things first. ABC, get an IV access, see if the patient is unstable or not. Then if the patient is unstable, you go for cardioversion. Keep things simple. The more complicated you try to make things, the more you put yourself at risk of making very big errors. So broad complex tachycardias are like high risk, high reward. If you get things right, your patients can become completely resolved of their symptoms very, very quickly. But if you get things wrong, patient can go into cardiac arrest. So it's like high risk, high reward, and you have to respect that. So the criteria that you generally use are the Brucada criteria, the Vereke algorithm, and there is a Sasaki rule. Sasaki rule is like less commonly, taught, but it is supposed, and it's not really validated that much compared to the other two, but it is supposed to have a higher sensitivity and specificity compared to the other two. We'll go through each of these today. So the Brucada algorithm and the Brucada criteria is as follows. You have four things. You look first of all, you look for concordance. That is the absence of RS complex in any precordial list. That is concordance. Then you look at the R to S interval, onset of R to the nadir of S, whether that is prolonged, and by prolonged you mean more than 2.5 small squares or 100 milliseconds. Next you look for whether there are features of AV dissociation, and finally you look at the morphological criteria. So the initial the study which looked at it had very, very high sensitivity specificity. The later studies that looked at it didn't have that good results. So that is a disclaimer for this. So how do you actually remember this? You can use a mnemonic. The commonly used mnemonic is CRAB, CRAB. C is for concordance, R is for the R2S interval, A is for AV dissociation, and sorry, CRAM. So and M is for the morphological criteria, CRAM. And we'll go through each one by one. One is absence of RS complex in non-precordial leads. What does this mean? We are basically you're looking for concordance in the precordial leads. What do you mean by precordial leads? V1 to V6. V1 to V6 is your precordial leads. And you look for basically whether all the QRS complexes are going in the same direction or not. So if all of the QRS complexes are moving in the same direction, then that is VT. That is not SVT. That is definitely VT, and you should treat it as VT. So if that is not there, the next thing that you should look for is your Brugada sign. So there are some confusing terminologies here. One is the Brugada criteria. Next is the Brugada sign. Then you have the Brugada pattern on the ECG. That is a completely different thing. That is used for diagnosis of the Brugada syndrome. Just something that is completely not relevant to this talk. That is something that you look for in patients who present with syncope to the emergency department, where we look at those things. So don't get confused with Brugada syndrome and these things. They are completely different. Same name, but different things. So with Brugada sign, basically you look for from the onset of your R wave. Look at the green thing here. Onset of R wave to the nadir. That is the lowest point of the S wave. And look at the duration of that. And if that is more than 100 milliseconds, that is more than 2.5 small squares, that favors VT. Another thing that you can look for is something called the Josephson sign. That is, look at the downslope of the S wave, and if you see a notching of the downslope of the S wave, that is a Josephson sign, and that favors VT. But in the Brugada criteria, we are only having this the Brugada sign. That is the onset of R to the nadir of S. That is more than 100 milliseconds. Next is AV dissociation. AV dissociation is basically you have QRS complexes going at a particular rate. Then you see P waves, which are actually marching out at a different rate to the QRS complexes. So they are dissociated from each other. That means the ventricles are beating at their own rate. The atria are beating at their own rate. Similar to what happens in CHP, but here it is actually a tachycardia. This is actually very difficult to actually see on the ECG because patient will generally be unstable. They'll be moving around a little bit. So it's generally going to be very difficult to actually figure out whether that is actually a P wave or whether that is just some motion artifact. But again, this is something that you have to look for as per this criteria. You want to look for other things also, like your fusion beats and your capture beats. If you see these things, it is 100% VT. So fusion beats is that in between the broad complexes, you see a somewhat a narrow complex, not quite narrow as narrow as normal, but something in between broad and narrow. That is your fusion beat. Capture beat is that in between the broad complexes, you get a narrow beat. So those are capture beats. So if you see these things, they are diagnostic of ET. So those were the relatively easy parts. The difficult part of the criteria is actually the morphological criteria. So this is how we actually look whether basic funda of the morphological criteria is whether the pattern is actually fitting with the normal RBBB or whether it is not looking like an RBBB or LBBB, is looking like something else. So as I said earlier, the only way that you actually diagnose SVT with bundle branch block is if you have the RBBB and LBBB morphology perfectly in lead 1, V1, and V6. As per Brugada, we are only looking at V1 and V6, but practically for RBBB and LBBB, you have to look at all three leads. So the morphological criteria is going to vary based on whether it is an RBB-like pattern or an LBBB-like pattern. What do you mean by an RBB-like pattern? You have an big R wave in V1, the big positive wave in V1 that goes to the RBB morphology, and a big S wave, big negative wave in V1 goes towards a LBB morphology. So in RBB morphology, what are the things that actually favor VT? So one thing is if you have a completely monophasic R wave, smooth R wave, that is actually not typical of an RBB that favors VT. Secondly, you have a taller left rabbit ear. Now, what does that mean? Usually, when you have an RSR dash pattern, the initial R wave is going to be smaller compared to the R dash wave. That is usually what happens in RBVV. If the opposite happens, that is, as you can see on this photo here, the left side of the RSR dash pattern is actually bigger than the right side. So that is called the taller left rabbit ear pattern. So the ears of a rabbit, basically. So if you see that, then that is actually going to favor VT. Also, if you see any QR complexes, any kind of Q waves before the R wave, that also favors VT. So this is for V1 and V2. What about V6? Again, in V6, generally you have slurred S waves, but you are not supposed to have completely negative waves in RBVB. If you have completely negative waves, QS complexes, that favors VT. Similarly, if you have an R by S ratio of less than 1, that means that the R wave, the positive deflection in V6 is less than the negative deflection in V6. That again is not typical of RBB, that favors VT. So I'll review for RBB morphology V1 to V2. If you have a big, smooth monophasic R wave, taller left rabbit ear, or a QR complex, that favors VT. In V6, if you have a QS complex or an R by S ratio of less than 1, that also favors VT. Now, changing towards LBBB. LBBB in V1 to VT, V2, what are we looking for? So the initial R wave duration, if it is more than one small square, that is favoring VT. So what does this mean, basically? It means that when you have an SVT with bundle branch block, what usually happens is that the terminal part of the QRS will get prolonged. That is what usually happens in a bundle branch block. Like your RBB, you're getting an extra wave at the end, that is your R dash wave. So usually it's the terminal part of the QRS that gets prolonged. But if the initial part of the QRS is getting prolonged, that is going to happen in VT. So the initial part of the QRS getting prolonged, that is what typical of VT, and that is what you are actually looking for when you are actually describing these criteria. So the initial R wave that is marked A here in the photo, if it is more than one small square, that is favoring VT. Then you have a Joseph's side. I've already mentioned that the slurring or notching of the downslope of the S wave that again favoring VT. Then there is a slight modification here. The RS interval for the time from the R wave onset to the S wave nadir in LBB morphology, anything more than 60 milliseconds is actually favoring VT, which is slightly different from the Brugada sign that I mentioned earlier, which was applicable for all these things, which was more than 100 milliseconds. For LBBB, it's slightly modified, which is 60 milliseconds in V1, V2. What about in V6? If again, similar to RBBB, if you have QS waves, completely negative waves in V6, VT. Or again, if you have a QR complex in V6, any Q waves, VT. So these are again the morphological criteria. And after hearing this, you will understand why I'm not a very big fan of these criteria in the emergency department, because it is very easy to get confused by these things. It is very easy to make the wrong decision. It is very easy on the basis of that wrong diagnosis to give the wrong medication, leading to bad outcomes. So again, we'll just for academic purposes, I'm explaining this in detail. Again, just review RBV morphology V1 to V2. Monomorphic R wave, taller left rabbit ear, QR complex, V6, QS complexes or R by S ratio less than 1. For LBB, V1, V2, initial part of the QRS. The initial R wave more than one small square, VT. The R to S interval more than 60 milliseconds, VT, or the Josephson sign, that is the fragmentation of the downslope of the QRS. And again, in V6, again, you get there completely negative wave that favors VT, and the QR complex that again favors your VT. That is all about the Brugada algorithm. Now, what about Vereki? For Vereki, there is. I'm not going to go through the entire thing because lot of them are going to be similar. But the extra thing that is going to be here is to look at AVR, which I actually think is useful. Because what is the importance of AVR when you're looking for broad complex tachycardia is that your lead AVR is on your right shoulder. Usually, how does a ventricle depolarize? They will depolarize towards your left leg because the left ventricle is generally bigger, so the net depolarization vector will be going towards your left leg. If you have a big R wave in AVR, what does that actually mean? So, basic ECG fundamental, but positive charge moving towards an electrode produces a positive deflection. So depolarization occurring towards a lead causes a positive deflection. That means that the depolarization wave is actually moving towards AVR, which is the complete opposite of normal. And that can only be because of VT. I hope that made some sense. So big positive R wave in AVR, think of VT. So very, very simple thing to look for. Think of VT if you see this. On the flip side, if you see a dominant terminal R dash wave in AVR, like the top image here, that kind of favors an SVT, very, very classical of your TCA toxicity. But at least try to remember the big positive wave in AVR because that is going to help you diagnose VT. Other things that are not covered in the criteria, but I feel that it is kind of important. Always look for P waves lead to and V1. Sometimes the patient was having a baseline RBPV, LBPV. Patient developed sepsis. Patient developed a GI bleed. Because of that, patient developed a tachycardia of 140, 150. And it can look scary. You might not actually see the P waves very clearly initially. So you have to look at it closely. So because you don't want to mistake these arrhythmias for sinus tachycardia. And another clue in that case is always going to be usually the rate for any tachyarrhythmia is going to be fixed, but for sinus tachycardia, there will be a gradual increase and decrease. So if you give IV fluids and if you give paracetamol for a patient with sepsis, you can see the rate coming down slowly. So that actually favors a diagnosis of sinus tachycardia. QRS duration, generally, the longer the duration, the more likely it is to be VT, but there are some exceptions that I will explain a bit shortly. Again, focus on the initial part of the QRS complex. If the initial part of the QRS is broad, very broad, like more than one small square, that again is going towards a diagnosis of VT. And obviously, if you see concordance, if you see fusion beats, you see capture beats, that is automatically VT. The Saki rule, it doesn't actually tell you anything different than the other rules. Only thing that it is a little bit more simplified compared to the other things, the other two. So if you again AVR big R wave VT, then you have the Brugada sign present, it is VT. The initial part of the QRS more than 40 milliseconds VT. So so generally I prefer the the idiot support approach broad complex tachycardia, which is basically assume that it is VT until proven otherwise. But if you really, really, really want to learn how to differentiate SVT from VT on the ECG, ECG with bundle bench block, I mean, these are the three most useful things I feel. Look for the big R wave in AVR, look at the Brugada sign, and look at the initial part of the QRS. These are the biggest clues that you can get to help you decide whether it is SVT with bundle branch block or whether it is VT. And it's always, when in doubt, treat as VT. And before we leave, we'll just go through one or two cases here. which I wanted to show as pitfalls. So, what do people think is the diagnosis here? Yedu, you want to try? What do you think is the diagnosis here? Yeah, I don't think he's online. Huh, ma'am?
Yeah, this is a broad complex tachycardia. I'm driving actually, so I'm sorry.
Huh, ma'am, no issue.
But I can see probably there's a maybe dissociation also with it. I'm very sure. Driving.
Okay, ma'am. Ma'am, I think you should focus on driving. I don't want you to go too deep into this thing
All right.
and crash.
Yes,
So,
I'll listen.
uh, okay, Parvati, you want to try, or what do you think is going on? Okay, so this is extremely important pitfall of whatever I taught you, because this is neither of the conditions that I taught you till now. There are two big things that you have to understand when you're seeing this. One thing is that this isn't actually that fast. One, see, if you look at the RR intervals here, it is actually more than the 3 large squares. So it's not actually fitting the criteria of VT. And very good. And Nilesh has actually said the diagnosis very good. So this is not VT. So unless and until the rate is more than 120, you cannot actually diagnose something as VT. Always keep that in mind. Second thing is you have a, definitely a broad complex, but it's actually very, very broad. And you look at the T waves here, you can see they are very pointed. There are other supportive findings, like there's actually some degree of first degree AV block, which is a soft sign of this condition. This is basic, and there is you can get some escalation in V1 as well in this condition, which is a pseudo STEMI pattern. It's not a natural STEMI. So it can actually mimic the Brugada pattern as well, which is something similar to this. But this is basically hyperkalemia. This is severe hyperkalemia. This patient's potassium was somewhere around 9. So don't get confused by this. If you try to treat this as a SVT or a VT, patient will die. This patient needs immediate hyperkalemia therapy. Don't wait for the VBG report. This can only be one thing. This is only going to be hyperkalemia. So don't get fooled into thinking that this is something else other than hyperkalemia. What about this one? What is peculiar about this tachyarrhythmia? I'll give this to everyone. Anybody with any ideas can give a guess. Anybody can take a guess. It's okay. Even if you're wrong, we are all here to learn only.
This has an RBBB morphology.
Yes. Yes, very good. People have spotted it. They have spotted the fact that it is irregularly irregular. So irregularly irregular means what usually? And we are not seeing any P waves, so it must be atrial fibrillation. So that is only one part of the diagnosis. So I'll agree that it kind of looks like RBBB, but I'm more interested in something else, and that something else is the rate. What is peculiar about the rate in this ECG? It is extremely fast, extremely fast. You can look at it. I think in AVL, you can look at that the RR interval is becoming as short as one big square. As short as one big square. That means at a rate of almost 300. The only way you can get that kind of rate is if you have an accessory pathway. So the diagnosis here is atrial fibrillation with WPW. Atrial fibrillation with WPW. And often these kind of rhythms can be seen with relatively young people because it's like a congenital thing. So if they'll present with tachyarrhythmia, you see this, and the patient might be looking very stable, and that is when you will get into trouble by giving AV nodal blockers. So if you give AV nodal blockers here, it will only increase the conduction through the accessory pathway, and the patient will go into something much worse like VFib. So the best thing when you see this, this is one of the cases where it actually doesn't matter whether the patient looks stable. The safest thing to do is electricity. The safest thing to do for this thing is electricity. Don't try to actually play around with medications, amiodarone or diltiazem, metoprolol. Don't do those things. The safest thing is electricity. And if there's one thing that I would like to convey is that electricity is very, very safe. The only thing that I will always advise you is that when you're giving electricity, patient should not feel any pain. Make sure that you have given adequate procedural sedation. Because you are not supposed to give patients PTSD after giving shock. So they should not have any recollection of what happened to them while you were giving the shock. Otherwise, shocking is very safe, and this is one rhythm where you have it doesn't really matter whether the patient is stable or unstable. You are going to shock this because the drug that you can give is procainamide, which is generally not available in India. So you just have to shock this. So again, we'll just rewind again. Always keep your ACLS rhythm algorithms in mind, but remember that ACLS was not made for each and everything that you will face in the military department. Like the things I showed here. If you follow ACLS for this thing, then you will give the patient amiodarone and patient will die. Because amiodarone is just going to make a hyperkalemia, ECG changes worse, and patient will die. So for some things, ACLS is actually not good, but for other things, ACLS is to be followed. So even for if with the WPW, that is actually not actually covered by the ACLS algorithm. So that is why I particularly took these things out to give them stress in this lecture. But otherwise, always look for the signs of instability. Hypotension, altered sensorium has the signs of shock, ischemic chest pain, and heart failure. If it is there, then you're going to the electrical cardioversion pathway. Other, if it's not there and the patient is stable, then you can start considering different types of medication depending on the arrhythmia that you have in front of you. So these are the references that I would like to mention that I use for making these slides, and I find extremely useful while learning ECGs. Smith ECG blog, Life in the Fast Lane, Ken Groer's ECG interpretation blog, and Dr. Amal Mathu's YouTube videos on ECGs. All of these are very useful resources. Of course, you can also refer other books as well. But I feel for taking your ECG reading skills up from average to above average, these are the things that you have to refer in order to do that. So that is all for today, and I will stop here and ask for any questions that anybody might have regards to the lecture, and we'll try to solve that now. So if anybody has any doubts, then feel free to ask now.